Thank you very much. Thank you for inviting me to this conference. So today we're going to talk about metabolic dysfunction-associated steatotic liver disease. And this is basically the new nomenclature for MASLD. This is the outline of the talk. So let's talk about MASLD, the history. The first description was in 1980 by Jürgen Ludwig, and the description was non-alcoholic steatohepatitis. At the time, fatty changes in liver biopsy were mostly associated with alcohol. And the observation here was that there was histopathological findings resembling known alcoholic steatohepatitis in patients who denied alcohol intake. And over the years, the definition became more clear. And as the name dictates, it required the exclusion of excessive alcohol consumption. And the definition of excessive alcohol consumption was more than 20 grams per day for male and more than 10 grams per day for female. There were some issues with this nomenclature. First is that using the term non-alcoholic didn't really capture the main etiology driving this condition. Second is fatty can be stigmatizing. And third is that you assume that these patients do not consume alcohol, but many of those patients would consume alcohol. So this brought another nomenclature, and maybe many of you were aware of this, the MASLD, Metabolic Dysfunction-Associated Fatty Liver Disease. The main difference is that it includes patients with fatty liver changes, regardless of the amount and pattern of alcohol consumption. And for the diagnosis, you required a fatty liver on imaging or biopsy, and at least 1 out of the 3, being overweight with a BMI of more than 25, having diabetes. And if you don't have either of those, then you should have at least 2 risks of metabolic disorders. Again, there were some issues that didn't really lead to the widespread adaptation of this nomenclature. One is mixing etiologies, so you really cannot really say what are the other causes that may lead to fatty liver. The term fatty, again, was considered by some to be stigmatizing, restricting the population to 2 metabolic risk factors and allowing more liberal use of alcohol. So this can impact our understanding about the true natural history. So because of these reasons, the 2 main authorities in liver disease, ASLD and EASL, along with other international bodies, had a multi-stakeholder effort to resolve the issues with the nomenclature. And by June 2023, there was a new consensus with a new term, and this is MASLD, Metabolic Dysfunction-Associated Steatotic Liver Disease. And we're going to talk more about this. So the bigger umbrella of the term is steatotic liver disease, meaning basically just fatty liver. On the left here, you can see the main thing that we're going to talk about is metabolic dysfunction-associated steatotic liver disease, or MASLD, which mostly resembles what you know as NAFLD in the past. And then here on the right, you have another term called metabolic alcoholic liver disease. And this is when you have MASLD and increased alcohol intake. And the physician can decide if this metabolic alcoholic liver disease, is it mostly MASLD predominant when the alcohol consumption isn't that significant, or ALD predominant when there is more significant alcohol consumption. If you don't fulfill the criteria for metabolic dysfunction-associated steatotic liver disease, or MASLD, and the patient consumes alcohol, then this is alcoholic liver disease rather than NAFLD or MASLD. And if alcohol is not an issue, it's not a main issue in terms of consumption in the patient history, then you look for other causes that will lead to the presence of fatty liver. And if everything else is negative, then you can label the patient as cryptogenic SLD, or steatotic liver disease. To go through this step by step, so we'll start with steatotic liver disease. So this is a patient presenting to you with fatty liver, and this is hepatic steatosis identified by imaging or biopsy. The first question you want to ask yourself, does the patient meet any of the cardiometabolic criteria here on the right? And those are being obese or with high waist circumference, have evidence of high fasting serum glucose or high HbA1c, or being on treatment for diabetes, high blood pressure, high triglycerides, or low HDL. If they do not meet any of these criteria, then you have to ask, are there any other causes of steatosis? If there are no causes, then this is cryptogenic steatotic liver disease. If there are other causes, then you can label it according to the cause that you identified. And we're going to talk more about this later. On the other hand, if the patient fulfills the criteria of cardiometabolic criteria, then they can have MASLD, but you also want to know if there's only MASLD or there's something else. So specifically, you ask about alcohol. So if it's only there's no other causes of steatosis, then this is MASLD. And if there are other causes, specifically, let's say alcohol, then you can label it as metabolic alcoholic liver disease. And as I tell the trainees, the residents, and the fellows all the time, when the patient comes to you with fatty liver in the clinic, please think about the other differential diagnosis. Don't just point to the to NAFLD or MASLD. So you have to think about other causes. Other causes of fatty liver include excessive alcohol consumption, hepatitis C, lipodystrophy, acute weight loss in patients who underwent bariatric surgery or those who suffered from starvation, malnutrition, TPN, patients who are pregnant who have HELP or acute fatty liver of pregnancy. Medications can give you fatty liver, including steroids, amiodarone, methotrexate, tamoxifen, valproate, and antiretroviral medications in HIV. And other rare causes include Wilson and alpha-1 antitrypsin deficiency. So we did identify MASLD as a patient who have fatty liver. And at the same time, there are risk factors, metabolic risk factors associated with that. Once you identify a patient of MASLD, you need to know if it's just the majority of patients who have MASLD who have simple hepatic steatosis, or there are the subset of patients who will have progressive liver injury with fibrosis. And this is what we call NASH. So that's the main difference between MASLD, or previously known as NAFLD, and NASH. In patients who have NASH, they will have hepatic steatosis with evidence of cellular injury and inflammation with or without fibrosis. And those are the patients who will eventually have developed cirrhosis on the long term. MASLD is common. It's the most common liver condition, and it's affecting anything between 20 to 30% of the general population. In the Middle East, we don't have a lot of data, but it's estimated to be up to 32%, one of the highest regions in the world. It's important to identify the risk factors of MASLD, and we talked about those. Those include obesity, diabetes, hypertension, dyslipidemia. And even with those patients who do not fulfill these criteria, you have to look into the lifestyle and the type of diet that the patient is taking. This is a slide showing you the pathogenesis of MASLD. We'll not go through all of it, but the main issue here is that the energy intake exceeds metabolic needs. And with that, you are reaching stress capacity for the adipose tissues for fat storage. And this will lead to adipose tissue inflammation and insulin resistance. And this will lead to increased free fatty acids. These free fatty acids find their way into the liver. There are different pathways for these free fatty acids, but one of the main ones is that you are creating lipotoxic lipids, which leads to ER stress, oxygen stress, inflammasome activation. This will lead to all the hepatocyte injury. At the same time, just to talk about the effect of or the association between fatty liver and cerebrovascular accidents or events. If we have too much free fatty acids, you're producing more triglycerides, more VLDL, and then we're increasing the risk of cardiovascular disease. This diagram shows you the natural progression of fatty liver or MASLD. So it can go from normal to non-NASH or MASLD, and the vast majority or the majority of patients who have fatty liver will have the non-NASH form. Some of these patients will develop NASH, and with NASH, you're going into progressive fibrosis. We have four main stages of histological fibrosis. F4 correlates with cirrhosis, and once you're cirrhotic, you have increased risk of decompensated liver disease and hepatocellular carcinoma. It's important here to note that the most common cause of death in patients who, even of those who do not really progress to end-stage liver disease, is cardiovascular disease. And this is another diagram just reiterating this. So we have here the healthy liver, and these are the changes that we see in NAF of the steatosis. You can see all these small yellow spaces here correlating with fat in the liver. And then at the end here, when patients who have cirrhosis, you have these fibrous bands suggesting cirrhotic changes. There is an established association between MASLD and metabolic syndrome. We already spoke about that, but there is also an established association between MASLD and the risk of coronary vascular disease, independent of other established risk factors. And there are many studies that looked into this. One example here is a meta-analysis of more than 34,000 patients. You can see that the odd ratio of developing these events is 1.64. So this is important for us because as a gastroenterologist or a hepatologist, I can focus more on the liver, but as like my colleagues, let's say in internal medicine, endocrinology, or even primary health care, your role is very important to address the other risk factors for cardiovascular disease and address them to help the patient in the long run. How does MASLD present? It's mostly asymptomatic. Uncommonly, some patients may present with vague right upper quadrant pain or fatigue. It's very important in the history that you establish what's the alcohol consumption history. On imaging, you will find fatty changes, or sometimes you can find hepatomegaly. In most patients, their liver enzymes would be normal. Some of them will have mild to moderate high ALT, AST. ALT is usually higher than AST. If AST is higher than ALT, then you have to think about the possibility of advanced fibrosis. Alkaline phosphatase may be increased in some of these patients. And there is not an uncommon presentation if the patient have high ferritin. They just have fatty liver. They don't have iron overload or hemochromatosis. We just asked if you see that, just check the iron saturation. Usually it will be normal. Uncommonly, some of these patients will have low titer high ANA. In these cases, if you rule out other causes of autoimmune disease and rule out autoimmune hepatitis, they are clinically insignificant. A common scenario that we get in our clinic, patient comes to primary health clinic or internal medicine clinic with complaints of abdominal pain, ultrasounds done that shows fatty liver, and the patient's referred to us for assessment. So as I explained earlier, it's very important for us to know if the patient have simple steatosis or they're developing the subset, what we call NASH. And these are the patients that we worry about because these are at increased risk of developing progressive fibrosis and cirrhosis in many years to come. And one of the main ways that we need to address that is to establish if the patient have liver fibrosis. The gold standard to establish liver fibrosis is to do a liver biopsy, but it's obvious it's very invasive. So we try to avoid it in many cases. And we have non-invasive methods that can help us. One of these non-invasive methods is serum biomarkers. We have different serum biomarkers, including the NAFLD score and FIB-4. For you, I think it's very important that you are familiar with the FIB-4 score because this is an easily obtainable result that you can get from the patient's age, ALT, AST, and platelet count. You can look it up online and you can just get the score right away. It has a sensitivity of 65% and a specificity of 70%. If you have a result of less than 1.45, have a negative predictive value of more than 90%. And if you have the result of more than 3.25, it has a positive predictive value of 65%. You may get indeterminate results in up to 30% of the cases. And this can be affected also by the age and active hepatitis if the liver enzymes are already high for other reasons. Another method to assess fibrosis is a fibroscan, and we use that in our in the hepatology clinic. We usually use a cutoff of around 8 kilopascal to determine if the patient have advanced fibrosis or not. And the third way is MRI elastography. This is the most accurate non-invasive imaging-based biomarker of fibrosis in NAFLD. Unfortunately, it's not widely available. So to put everything together here, if you can see here in the graph, how do you deal with a patient who presents to you with MASLD? Now, this is in the non-GI setting, and this is in the GI setting. The main thing you need to do is to see if the patient have any evidence of advanced fibrosis, and you can easily use a FIB-4 score. If the FIB-4 score is not high, then you can refer the patient to us, but you can also be comfortable to follow the patient regularly. You can reassess the FIB-4 score every 1-2 years, establish if the patient have any other risk factors and treat them like diabetes or dyslipidemia or hypertension. But on the other hand, if the patient have high FIB-4 score, then you can do further testing. You can refer the patient to us, or there are other scores that you can use. Now, if the patient have high risk, this is where we do this in our clinic. We check the liver function. We see, we do our FibroScan, and if the results are indeterminate, we can do liver biopsy to confirm. And we can also establish if the patient's cirrhotic or not, and we can manage the patient accordingly. So the mainstay of management of MASLD is weight loss. And what we tell our patients that we need to lose 5 to 10% of your weight over 6 months by diet and exercise. If you lose 3 to 5%, you will improve steatosis. But if you lose 10%, even if the patient have advanced fibrosis, of course, not to the point of cirrhosis, but I would say F2, F3, this can improve NASH and fibrosis as well. And sustained weight loss reduces adipose tissue stress and peripheral insulin sensitivity. But this is a challenging issue. It's easier said to the patient that you need to lose weight, but the reality tells us that around 30% will achieve 5% weight loss, and 60% of those will gain weight back in 1 or more years. We talk to our patients about the type of diet that they're having. Things like excess calories, saturated fats, refined carbs, and sugar-sweetened beverages will increase the fat in the liver. And even if those who they're not overweight, their diet can dictate that they are. This is the reason why they're having MASLD. And also excess fructose consumption. This increases the risk of MASLD, NASH, fibrosis, independent of the total calorie intake. We tell our patients to lose weight. Any diet that works for them, we're happy with. But if they want a specific diet, we do recommend the Mediterranean diet. We recommend activity regularly, and they have to, as my colleague mentioned earlier, to exercise at least 150 minutes per week. And we ask them to avoid certain foods that will increase the risk of increasing fatty liver and liver inflammation and fibrosis. It's a process. How we deal with NAFLD patients, it involves many parties. So the primary care provider, the endocrinologist, they refer the patient to us. They address the other cardiovascular risk factors. We work on the liver, rule out the possibility of NASH and advanced fibrosis. And dietitians can help us a lot in achieving the weight loss goals. Most patients who are undergoing bariatric surgery have MASLD, and bariatric surgery can resolve NASH in some studies up to 80% in 1 year, and they improve fibrosis. Patients may have persistent NASH after bariatric surgery, but this is mostly in patients who have sleeve gastrectomy more than those who have Roux-en-Y gastric bypass. We don't have good data for cirrhosis, and we only would recommend it in very highly specialized centers. What about pharmacological therapy? We do not recommend pharmacological therapy for MASLD unless the patient have evidence of NASH, something to say that he has ongoing fibrosis. And we'll not go through all of those, but the main 3 agents that they're still not FDA approved for MASLD, but they can be considered in the guidelines, are vitamin E if the patient does not have diabetes, bioclidazone, and more recently in the latest guidelines, semaglutide can be also considered. It's important to say that there are studies to show that they improve the fat in the surgical findings of fatty liver, they improve NASH changes, but no significant improvement of fibrosis. And this slide just to show you the management. So if it's just hepatic steatosis, lifestyle interventions, if the patient have diabetes, we'll refer the patient back to their endocrinologist to focus more. We do consider if you can give the patient a GLP-1 agonist like semaglutide, if they agree. If they have NASH, then we can give pioglitazone. And if the patient is already cirrhotic, really we cannot give any treatment. We just manage the complications as they happen. Can I get this last slide, the summary slide?
Can we get the last slide?
Just one slide.
Because you've run out of time.
So in summary, MASLD is the most common liver condition. Most patients with MASLD won't develop clinically significant liver disease. Patients with NASH are at the greatest risk of liver complications. Patients with MASLD are at increased risk of developing cardiovascular events. Addressing risk factors is an essential component of management. The mainstay of management is 5 to 10% weight loss. And for NASH, there are non-FDA-approved pharmacological options, but we can consider them in certain cases, including vitamin E, pioglitazone, and semaglutide. Thank you very much.